Welcome to the very first episode of Keep On Loving, the podcast. We're here with our lovely co-host. My name is Javante, and I'm here with our co-host, Amia. Amia, we're filming.
Hi, Javante. How are you feeling today?
Podcast. I'm good. How are you?
I'm wonderful. I cannot complain today. Today's a great day.
I see you got your beverage.
Listen, I needed a smoothie. Like, we're right next to the Reading Terminal. Why not just run out and grab a smoothie?
Today is a beverage kind of day. Who do we have on the screen with us?
Today, we have Amina McCann Woods, who is the Health Programs Manager at ACO. And we also have Evan Thornberry. Oh, did I say it right, Evan? I always say Thornberry because I think of it like wild thornberries, and I'm
gonna change my name because that is common, and I'm just gonna change my name, honestly, and that also shows that we're from the same era. Continue.
Okay. Like it's Thornburg. Am I right? Okay, let's just. Can I redo that?
No.
We'll
cut it in the
editing.
Fine. The Keep On Loving podcast is about conversations. We're going to cut it in the editing. Go ahead.
Evan Thornburg, who is the Health Equity Special Advisor for ACO. And then we have me and you, Javante.
Yes. So I think we should tell the people listening and watching that the Keep On Loving podcast is a production of the Philadelphia Department of Public Health AIDS Activities Coordinating Office. So when we say ACO, we're talking about the AIDS Activities Coordinating Office, which is responsible for all of the coordination of care and prevention relating to HIV in the city of Philadelphia. But we know people are watching this from all over, so the conversation is going to be relevant to you. What are we talking about today, Amia?
So we're going to be talking about National Black HIV Awareness Day. And I think having these special guests on today are the most perfect people to talk to today about this topic.
So what is National Black HIV Awareness Day?
National Black HIV Awareness Day was created about, I want to say, 20 years ago to help organize in my words.
It's okay. It's our first episode. It's okay. Get it out.
National Black HIV Awareness Day is just an awareness day to make sure that we are doing our best to make sure that African Americans from near and far are making waves and knowing that they can be HIV negative, knowing I was on a roll. I feel it. I'm sorry, I got nervous.
You feel it? It's okay. Don't be nervous. Ain't nobody even watching us. Except all of the millions of people who have access to watch us.
Right.
It's cool. We got you. So basically, National Black HIV Awareness Day is a time that you are saying we stop and raise awareness about HIV in the Black community.
Absolutely. Such as issues still as racism, discrimination, mistrust in the healthcare systems, and so on and so forth.
Okay. All right. Cool. So what are we talking about today?
So, I have some really good topic questions I think the people would like to know about. So we're going to be talking specifically around stigma, testing, prevention, all of these great things. So I do want to kick off the first question. And I want to go to Evan. And then I would like you to follow up. Why is there a Black HIV Awareness Day?
So it was founded in 1999, and it predominantly occurred because there was a need to draw attention to the disproportionality of HIV in the Black community, but also in how there's neglect in care. So that's the major component of having there be a National Black HIV Awareness Day. It's to have a conversation amidst and within the Black community about both internally the stigma that we pass along that is specific to culture or community, but also talking about internally amidst ourselves, and also sharing with the world about how we are left behind in a lot of the conversations about care, prevention, and centered in those conversations, even though we're a disproportionate amount of the population. The largest at risk group next to MSM of color, specifically Black MSM of color, is Black women, straight Black women. And so we need to be having these conversations. Um,
Absolutely.
and in Philadelphia, because we're dealing with a huge upswing in the opioid crisis, a huge part of our using population, our population that is prone to substance use, is also Black and brown people.
Thank you so much. Amanda, did you want to follow up and add anything to that?
One thing that stuck out from Evan's comments was the word left behind, because some of the left behind is not unintentional. Um, we have some intentional leaving behind of the Black community in relation to this virus. Um, since HIV is a virus, a virus will virus, it is spreadable to anyone. Anyone can contract HIV, no matter what color, age, religion, sexual identity, etc. And so we understand that in the earlier days in the 80s that this impacted, gay white men in particular. That's where all the attention went to. And because of that narrative, there was this belief that um, if you weren't if you weren't white, if you weren't gay, that this doesn't impact you. And so I know we'll probably talk a little bit more about this later, but that narrative still carries over 40 years later. So we have to unpack that
Absolutely.
still.
Absolutely. And this conversation actually will carry over because I really would like to know, and Javante, please jump in on this. What does HIV stigma look like in the Black community? Like, what do you see right now when it comes to HIV stigma? Especially working within a health institution. Um, what are some things that you are right now combating, and what things are you seeing that you are personally maybe combating or within the agency?
I can start. I think so. I'm in. When I was preparing for this podcast, one of the thoughts that kind of bubbled up for me was, as we're moving into a place of talking about HIV as a chronic condition, right, as a chronic health condition.
Hmm.
One of the things that I think stigma does to us is it refuses us iconography and joy. And so what I mean by that is that a lot of HIV work and a lot of HIV campaigns and a lot of HIV conversations, when they do involve the Black community, um, it's very medicalized, or it's very it's I think it's very sterilized, or it's just very much inside of like a you'll survive, and like that language is very important. But I also want us to, as a population, move into also thinking about HIV, because it's a chronic condition, as identity too, and that there can be living with HIV and joy, which is why I love the Keep on Loving um, campaign. I also love the I Am Art campaign that I forget which municipality that came out of, but these conversations about joyousness, even as a person living with a virus and a chronic condition. Because I think the more we talk about this in the language of chronic conditions, in the language of like hypertension or diabetes or even some forms of cancer, the more people are able to also combat stigma. And I think in the Black community, we still talk about HIV as like in the tone of curse or shame, or you've done something wrong. There's still a lot of homophobic language that unfortunately kind of bubbles around and boils inside of the Black community, depending on what part of the diaspora you're part of and from.
Hmm.
So that's my initial thoughts, but there's of course many more, but.
I mean, I'm going to yield to you.
I agree with Evan, 100%. I also, when I was preparing, I was thinking about, how does that look in our community? And, honestly, one of the first words that came to mind was bullying. It's, the use of, the language that is
Mhm.
in folks' vocabulary as it
Mhm.
relates to HIV or any,
Mhm.
I would say, any infection
Mhm.
or illness.
Mhm.
Like she said, she used the word curse. It's like, there's like, you did this to yourself
Mhm.
kind of tone.
Mhm.
And, you know, did your behavior contribute to that? Yes, because you may have had unprotected sex or you may have shared some works, but are you, is it your fault?
Mhm.
I don't like the language and I don't like that particular tone because I always say, regardless of how someone acquired it, they have it, and now we need to work at keeping them with us as long as possible,
Absolutely.
and whatever that looks like. The you know Sterilized and the word medicalized, yes. I for a long time, even now to the day, like the the icon that's attached to HIV and survival is still Magic Johnson.
Mhm.
Okay.
Mhm.
Um, in a lot of ways, that kind of gets on my nerves
Mhm.
because I know like plenty of people in my daily life who is living with this disease, who's thriving, with this disease, and have been for 20, 30, and some people their entire life, the whole span of this
Absolutely.
virus. And
Absolutely.
so um, I don't know how, and a lot of people know people too. They
Mhm.
know these same people as well. So I'm not understanding how, on one hand, where we bully folks behind their back or in their face, but on
Mhm.
another hand, you do have a lot of examples of where people are thriving.
Mhm.
Um, it's not connecting. Something's missing.
And I just want to piggyback on that, Amia, because Amina brings up such a great like point in the Black community, because I think there's HIV stigma, right, which is a burden that society really puts on people living with HIV
Mhm.
and what it means to just be around the conversation of HIV. Like there's a lot of people who will not say it. Um, but then we have to talk about HIV shame also,
Mhm.
right? And
Mhm.
HIV shame more so lives on the inside of people living with HIV, as if they are damaged or broken in some way, right? Or something has happened to make them less than. And I think that in the Black community, sometimes those two things are very interwoven and
Mhm.
married to each other. I was having a conversation with someone and giving a presentation on like resources for people living with HIV. And the person came up to me afterwards and said, my kids will never know. Never know. The reason I won't apply for housing specifically for people living with AIDS is because they will never know.
Mhm.
Right.
Mhm.
And another person who his parents lived their entire life not knowing his diagnosis. He was determined that they would never know because it would break their heart,
Mhm.
right? And when you think about this is a medical condition. Imagine what it would be like to tell somebody, it's like they'll never know I have asthma. They'll never know I have acne, right? And yet we don't think of it in the same way as a society. And I think that's some of the work to do on this particular occasion of Black awareness,
Absolutely.
is to raise the
Absolutely.
awareness of stigma, because we have technology and science that helps manage HIV as a chronic condition, but the social stigma is in many ways more damaging to the spirit and the soul than the disease is to the body.
Absolutely. Absolutely. I was actually just having this conversation with some friends yesterday, and we were just talking about how when you contract the virus, that how hard it is sometimes just to mentally, for as someone who has been doing this almost 6 years now, coming into this, I was the most hardest on myself with when it came to stigma, because it was very much, well, who's going to love me? I did this to myself. I don't like this medication. It doesn't make me feel well. So I understand that there is so much stigma that we absolutely need to break through, and we need the backs of our community and to be more present to be able to make these things known. You equal you is a real thing. I just want to put that out there.
Tell the people what U equals U is.
U equals U is untransmittable equals undetectable equals untransmittable. Any viral suppression lower, when your viral suppression is anywhere less than 12 copies, they can't even find it in your body. So it's like it's not even popping up. Sometimes even tests that are made to populate and find the HIV virus, sometimes it can go undetectable under that if within a virus. So it's really, really, really great. I think that the medications that are coming out now are super duper duper amazing, but I won't get into that right now. But when we talk about medications and we talk about treatment, we talk about prevention. Amina, let's take it over to you. How has care and prevention changed over the last 40 years?
Oh my goodness. So I've been in public health in the HIV space for 20 years. That makes me feel pretty dang old. But um, when I started out, it just made me think of my journey. I remember as a case manager, I would have a um, XYZ pharmaceutical company would come out with a poster of all the medications that are available, right?
Mhm.
And so I would put, every time I got an update, I would put that on my wall so I just kind of know, right? And we used the word cocktail, even then back in 2003. And, you know, as we move through this uh, disease, of course, we don't use that terminology anymore because we went from some folks taking upwards of 10, 20, 30, 40 pills. I mean, honestly, to some folks now can take a single pill a day. Um, so in the vein of treatment, that's just amazing. I remember my clients who would come in, and we would spend half our time talking about adherence and side effects. Because the you know calling it HIV high, what do they call it? Heart. It used to be called heart.
Mhm.
And now we're talking about eye art. Just the progression of the
Mhm.
language that we use and the number of medications a person has to take is just different. Now on the prevention side, and also, I'm sorry, I experienced a lot more HIV death or HIV or AIDS related deaths back in that time as well. It was a lot less than, of course, than my colleagues, who's been around a lot longer. But it was a pretty common thing to hear so and so pass away, or receive clients who were bedridden. I had a lot of clients who were bedridden during that time. So on the prevention side, again, I was there when we were doing lab-based testing only. We would draw their blood, send it to the lab. I remember the days when rapid tests came, and
So
it
wait,
was hoopla,
can I ask,
hoopla.
Amina,
Yeah.
what lab based? So we're going lab based. What
Okay.
year are we talking lab based?
So for me, I
Mhm.
entered into the space in 2003. Okay. So in 2003, we were doing um, blood draws to
Okay.
test whether or not someone was HIV positive or not, and they would have to wait up to 2 weeks to get their results. And then when rapid test came, the first results, same day results, was 20 minutes. It caused a hoopla because we were like, oh my God, people are not going to be ready to hear their information that quickly. Oh my God, what are we going to
It's
do?
the
It
longest
was
20
just
minutes of your
so
life.
crazy
It was
and
the longest
chaotic.
20 minutes of my life, I tell you.
Yeah. And I saw that. And then to where we are now, we have rapid tests. You get your results in 60 seconds. It is, we could do finger sticks, we could go oral, whatever direction we're going. And we talk in terms of third gen, fourth gen. I'm talking about it in terms of language, and in terms of my experience. And we've come such a long way. We have so many tools in the toolbox. Literally, the only tools in the toolbox when I started were testing and street outreach. That was the biggest tools we had. I remember. And then we moved to, that plus mobile testing and biomedical terms like PrEP and MPEP and all that. And so, we just come an awesome long way.
And just piggybacking on what you said, Amina, tools in the toolbox only work if you use the tools, right? And I know we could get into a conversation about that, about the lack of accessibility to Black folks, and how different communities have different levels of access. But you said something about the treatment and like the one pill a day, and left out that now you can get an injection every other month.
Yes.
Right?
Yes. And
Like,
yes,
it's
you are
continually
correct.
progressing, and there's a lot of things coming
Yes.
down the pipeline. So I just wanted to add that bit
Mm-hmm.
in there, because technology has increased so much around prevention and care. It is mind-boggling. The
Absolutely.
things that we have now, the folks who first encountered the AIDS crisis in the 80s would have loved to have access to, right?
Absolutely.
And
Mm-hmm.
I just get really hopeful and excited about what we have access, but we only have access to them if we have access to them.
And can I add one more thing? Just,
Nope.
as we were talking about Black AIDS awareness, AIDS, HIV Awareness Day, going back to the topic of mistrust, right? We have all these tools in the toolbox, like you said, but folks don't trust it. There's still a mistrust or there's misinformation. Okay. Um, so I don't know how we unpack that in this conversation, but um, now we're talking about biomedical. We're talking about, you know, medication entering the body. What are you doing? What are you putting inside of me? Why are you always pathologizing me? Why do you want me to take these pills? Why are you pushing these things in my community? Because there is a fatigue that exists, specifically with Black gay men, in this conversation. And the word targeting, I know we try to get away from that term as well. But how do we, I don't want to play host Amia, but how do we combat that
You can
part?
co-host on
That's
Keep on Loving.
serious.
So that was going to actually, it is okay because that was actually going to be one of my questions. I think that we have to, and this is just my everyday hat that I feel like that we need to be able to start talking about full body health, full body and wellness, because I believe that is what will make someone stay in care. When we have someone and we can have a participant who is coming in to get their medications at that doctor's office, is there a therapist on staff? Is there a psychologist on staff? What other services can they get? Is there a one-stop shop? What other things? Is there nutrition on? Because these are the things, like, does this agency able to help provide bus tickets to be able to get to and from? Because a lot of people, especially African Americans and um, low impoverished areas, are not able to get transportation a lot of times to and from places such as healthcare. So I believe that if we do, and when we are pushing, we need to push for more full body care. And that is something I realized, I believe once I moved to Philadelphia, I was so gun ho, and I definitely understand the targeting of this community, and it does then go help push stigma right on back on the backs of a community or communities. But I absolutely believe full body health is where the way we need to go and make, to ensure that we keep people that are infected, we make sure that we keep them negative, we keep them suppressed, and anybody that is negative, we make sure that we keep them negative. Evan, come on, throw something at me. You have the Evan, like you bring it on in. Bring it on in.
Um, One of the things that I think is really super exciting and important about the advancements in biotechnology around medication, especially, is that it's not just about the ease of access to medication, it's also medication that is now adaptable to our real life situations.
Mhm.
Um, a lot of people living with HIV are also living with interpartner violence or intimate partner violence. And one of the main components of intimate partner violence for people living with HIV is hiding medication, particularly for trans women of color. And so when I can go in and get my ART as an injectable every other month, it protects me from the kind of abuse that I might be living with. For people who are housing insecure or houseless, that oftentimes have to construct their own housing or their own shelter, having to keep medication on you, but also your housing is always at risk of being caught up in a sweep or a cleanup of the shelter you've designed for yourself means that you are constantly losing medication. Being able to get an injectable once every 2 weeks is so much more profound. The issues you were talking about with transportation, if I cannot afford transportation, having to go and get something refilled monthly or weekly is too much. But being able to do something once every 2 weeks is super affordable or more affordable. And also on the clinician side, because now you can say, hey, I only need transportation 6 times a year. You can accommodate
Mhm.
that. You can do full wellness on that, right?
Absolutely.
It is for some of our providers impossible to be able to provide the external element of adding the financial burden of making sure every consumer or client has transportation like weekly. But 6 times a year, you can do that. There's a way to do that. You can give me bus fare for that. So I think there's a lot more independence, but I think it also accommodates more people that are in scenarios that are super unideal, especially when it comes to the management of medication. So I love that. And we know that in a city like Philadelphia that has a very high poverty rate as well as a very high black and brown population, the predominant amount of people who are experiencing housing insecurity and IPV and anything in this city are going to be black people. And so that's what I love about the biotechnology in this. Um, I won't eat up all of our time because y'all know I can go in on some misinformation. this is my
Every
this is
time.
my area of like public health. This is the hill I plan to pass away on. Like misinformation and literacy are like in public health are just like oh such a
And
thing for me.
at this point, I believe that you are intentionally trying to drag me up this hill with you, because every time you say something, I'm like, didn't realize that or didn't think of that. And it makes my mind run like a little gerbil on a wheel. And now I'm on the hill with you. Like I
Right.
never thought inter partner violence on trans women, especially when it comes to being HIV. Like I didn't think of that, and it would be because I come in an era where 2 years into my status, um, we were already doing injectables. So we're making waves. I just want to take us out with this question. And as we take us out, I would like each of you to also introduce yourself again. If anybody has any questions or would like to further contact you about some information, please let the people know where they can find you. The final question for today is, what role can people help in HIV? Let's start with Javante.
Well, I'm glad you asked.
Right.
So
Woo.
it's all downhill from here. So I think, like the federal government has this initiative called Ending the HIV Epidemic. And a lot of initiatives have come about before this. Like we had Getting to Zero, we've had Fast Track Cities. Both of those things still exist. But I think the Ending the HIV Epidemic initiative, it has caught the attention and the collective hopes and aspirations of the community because for the first time in this epidemic, it's possible, right? With the treatment types that Amina was talking about and the different ways to prevent getting HIV, like it's preventable. It is a preventable disease, right? And so when we think about that, I'm really hopeful that people will educate themselves on how to prevent it, even if they're living with HIV, how to stay healthy. And you brought up a good point about U equals U. Undetectable equals untransmittable. If you are on antiretroviral medications to treat HIV and you are undetectable, our best science tells us that you will not transmit HIV to your partner through sex, right? And so that's game changing. That's game changing. And for anyone who's living with HIV who may have had shame or stigma, my heart and hope for you is that you will take this day to really understand how much you are worth and how special you are and how resilient you are. And that you've got a community of folks that are standing behind you. And so, like, this is a great time to pause and reflect on the work that we have done as a community, but also to move forward. So I'm a tag team Amina.
I'm gonna say two things. One, it sounds very cliche, but it's true. Just we have to just continue fighting the good fight. Um, there's like we already stated, there's so many options available to us. Something as simple as a condom, all the way to PrEP. Okay. Um, the second thing I'll say is, you know, you mentioned Javante about folks living with HIV, but the wonderful part about Black people um, in the whole diaspora and in this country is that we're resilient anyway.
Mm-hmm.
So we
Mm-hmm.
don't have to let a virus that is preventable um, be the thing that um, continue to plague us in the way that it is, right? Like, um, we just don't have to let it, And so when I say fight the good fight, when it's safe, got to put that word in there, to debunk a myth, to uh, take a friend or family member to get tested, to hand them some condoms, to hand them some lubrication, to recommend, a flyer, here's this thing I heard about, because that thing we talked about the other night, girl, you might want to think about this. And so, we always talk about lifting each other up. So let's put our money where our mouth is. I'll end it there.
Evan.
I'm gonna end in the way that my last comment ended, which is I really want us, and this is really my statement to clinicians and anybody doing care, is I want you to make your information consumable. You can have an empowered, participatory, collaborative consumer when they understand what's happening, when they understand the medication, when they understand the importance of this, when they understand their genetic risks now. And so we can let go of highly scientific language when we're communicating what we need to communicate. We can stay conceptual without having to be academic, right? It's very egotistical of us. And so I want us to do everything universally with low health literacy in mind, because I think the more people understand, I think the more, I've never seen a case where people didn't want to feel better or be better or manage or take care of themselves. People want to live long lives. But when they don't understand, they don't participate. And you need consumer participation. So you should make the information easy to consume. If I need to be able to explain it to my 3-year-old. I have a 3-year-old goddaughter. If she can understand it, then everybody can understand it, and that's what's important.
Well, thank you all. I'll end with one thing, and this is to the community, and that is to be honest with your provider. They can't do nothing to you. They can't beat you. They can't put you on punishment. There's no reason not to be honest with someone who is there to help you with your health. The more you're honest, the more they can do what they need to do to make sure that you're safe. So please, 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 when you're going to see your healthcare providers, please be honest about everything. So
Yeah.
we did it!
Episode of Keep On Loving the Podcast. What were you going to say before the audience started clapping?
I was going to literally say we did it, but I'm so excited that the
Yes.
audience clapped
Yes.
as I said we did it. Yes, we did it.
They should not have shown me where that button was, because I am going to play those claps, and the audience will absolutely love it. So that is it for this first episode of Keep On Loving the Podcast. Okay, y'all need to calm down. Y'all need to calm down.
I was about to.
They're about to go ahead. Everybody, we'll see you in the next episode. Take care.